Welcome and thank you for tuning in to this webinar produced by the Harvard Global Orthopaedics Collaborative. For those of you joining us for the first time, as a way of introduction, the Harvard Global Orthopaedics Collaborative is a group of Harvard-affiliated orthopedic faculty and trainees dedicated to improving access to musculoskeletal healthcare globally. The following is a recording of a virtual meeting on April 2nd, 2021, on the topic of traditional bone setting in sub-Saharan Africa. We heard from Dr. Adedamola Dada of Nigeria, Dr. Mengistu Gebreyohanes of Ethiopia, Dr. Malick Diallo of Burkina Faso, Dr. Henry Ndasi of Cameroon, Dr. Ndubuisi Onyemaechi of Nigeria, and Dr. Dominic Konadu-Yeboah of Ghana.
Thank you so much. My name is Elizabeth Card, and I'm a medical student, fourth-year medical student at the University of Pennsylvania, matched into plastic and reconstructive surgery. And I have the honor to help moderate this meeting today. I spent some time in Tanzania and researched patient perspectives of traditional bone setting, as well as interviewed traditional bone setters themselves about their practice. And before I introduce the panelists, I just want to introduce or define traditional bone setting for those of you who maybe haven't heard of it before. So it's essentially traditional healing for musculoskeletal injury. And it's most commonly known for treating traumatic fracture, but also traditional bone setters have been known to treat kind of everything that has to do with musculoskeletal injury. So chronic back pain to things like congenital problems like club foot. And it's a really ancient practice. So this is how we cared for musculoskeletal injury prior to the invention of orthopedic surgery and modern biomedicine. So it's been going on for thousands of years and it was practiced all over the world. And it remains today actually the primary form of care for a lot of musculoskeletal injury and disease, basically due to the fact that it can sometimes have greater geographic accessibility, financial accessibility, and cultural accessibility. And, it's still practiced in many pockets throughout the world, but today we're just going to focus on East and West Africa. And it's a controversial practice because it can result in a lot of complications that end up presenting to orthopedic surgeons pretty late. And so some would argue that it should be abolished completely, but others think that if we train these individuals, they can be incorporated into our orthopedic care and our larger healthcare system and improve overall access to care.
We hope you enjoyed the presentations and discussion. Thank you again for tuning in.
Well, good afternoon, everybody. I hope you can hear me. So let's start sharing the slides. I'm going to try to use some data to actually explain the issues around this phenomenon. Traditional bone setters, like we all know, like has been rightly introduced by the last speaker, it's a problem not just in Africa, it's widespread in Africa, particularly in Nigeria and I think West Africa, but it's also in some European countries. There have been publications from Turkey. There has been some publications also from the Asia countries, particularly India. So it's basically a problem, if you like, of developing parts of the world. Okay, next slide. Now, using some of the data that I'll be presenting, I'll try to, as much as possible, explain to you the challenges and the problems that are posed in the health system by these categories of people. Like we all know, the trainee is usually shrouded in mystery. A lot of the practitioners actually didn't undertake any formal or indeed, to some extent, informal training. Many of them take it as a family trait that is said to be passed down from generation to generation. And I'm sure we all know what the problem with that is. There is no quality assurance, there is no syllabus, there is no formal teaching, okay? And there's actually no way of actually assessing the level of knowledge of the practitioners, okay? This is a study that I did some time ago, and I'm going to run through some of this data to actually explain to you the characteristics of the practitioners of this profession, and then at the same time, the kind of problems that they cause within the system. Okay, as you can see from this particular, slide, it involves virtually all age groups, even the newborns, people that are 1 day old, okay? Sometimes we see them, those who have birth injuries, okay? And then, of course, the very elderly, okay? So the next slide. Okay, and then the occupation, you would think that maybe because of the kind of services that they render, that they would actually be serving only the low socioeconomic group in the country, but that is not so. You find out that they serve virtually all, regardless of the kind of job or the kind of education that people have. Okay, if you look at this data, you see that even health workers sometimes patronize them, professionals actually patronize them, students, very senior civil servants, and all of that. Next slide. Okay, and then the educational status, 65% of their patrons actually are people who have college educations and above. Okay, like you can see from this slide, about 18% of those who patronize them, these are data that were actually obtained from those who had patronized them at the time this study was done. About 18% of them actually had university education. Some of them are actually university lecturers, may be surprised about that. Okay, 35% actually had college education, and overall you have about 65% of their patrons having secondary education and above. And what this means actually is that the educational status of their patron is not so much of a determinant factor of those who patronize them. Next slide. Okay. Now, what type of injuries do they treat? Well, they treat all types of injuries. Okay, right from birth injury, you know, maybe a child during delivery develops a bone fracture or something, assault, all right, falls from heights, okay, falls while walking, road traffic accidents, pedestrian injuries, okay, even back pains and all of that. So they treat virtually all types of injury. The same types of injury that the orthopedic surgeon treats in the orthopedics department are basically the same thing that these guys treat. So they treat all categories of injuries. Now, next slide. Okay. And then what are the types that they treat, including some, you know, there are sometimes, as a matter of fact, some of the patients that have treated the most saddening thing about some of the patients that I've seen is that some of these patients have soft tissue injuries, no bony injuries, just pure soft tissue injuries, sometimes soft tissue contusions, okay? And then they go to the traditional bone setters, and because these guys have very dubious method of arriving at their diagnosis, it becomes extremely very difficult for them to actually differentiate between patients who have bone injuries and those who have soft tissue injuries. And then they treat some of these soft tissue injuries and convert these soft tissue injuries to far more serious problems for the patients. And then, of course, the majority of the injuries that they treat are actually closed fractures, okay? And some of them treat open fractures, but one thing that is quite a bit dominant about their practice is that many of them actually try to avoid open fractures, perhaps because of the bleeding that goes with open fractures, perhaps because sometimes, particularly with severe open fractures, you may have the bones exposed, okay? So quite a number of them try to avoid the treatment of open fractures, but they treat a lot of closed fractures, and unfortunately, pure soft tissue injuries that maybe sometimes with rest would heal, some of them treat these injuries and they convert them to a lot more serious use. Next slide. Okay. Now, another interesting thing that you may find is that a number of these patients actually first present to hospitals when they have these injuries, okay? All right, and when they present to hospitals, quite a number of them present quite early, within the 6 hours period, okay? But they usually, if they are going to get discharged, they usually would leave within the first 2 to 3 days. Then the first 3 days, they leave the hospitals, okay? And in this particular series, for those of them who eventually ended up with traditional bone setters, when they left the hospital, they didn't go to another hospital. And within 3 days, they had left the hospitals to be discharged to the traditional bone setters. Now, when we asked them the reasons for their discharge from the conventional hospitals to the traditional homes. A majority of them, about 34% of them, says is as a result of pressure from their family and friends. And you must realize that in Africa, there's a lot of social support system, particularly when there are injuries or when there are accidents or when there are illnesses, okay? You have a lot of the family members coming around, and some of this, and because of the social support system, some of the family members and friends would actually contribute to the care and the treatment of the patients, okay? And because they're going to contribute to the care, to the financial the cost of the treatment of this patient, they have a lot of influence on these patients. So about 34%, usually when they present in fact to the hospitals first, that about 34% of them are pressured by their families and friends to seek alternative care, okay? In about 30% of cases, the reason is dissatisfaction with the services. I'm going to say a little bit about this in some other slides. And then it's only about 17% of reasons why they discharge from the hospital to traditional Bonesetters, okay? Only 70% give financial reasons, okay? So it's actually not a case of the conventional hospitals being more expensive, like I've seen so many writers say in their papers. In actual fact, we tried to compare the financial care, the financial cost in the conventional hospitals to the financial cost in the traditional homes. The difference is not in the final cost of treatment. It's actually in the fact that whereas in the traditional homes, they allow them to pay, you know, if you like, you can call it pay as you go. They pay a little at a time, all right? Unlike in the hospitals where you have to give a bulk payment, okay? And then the last major reason is what they call the spiritual care of the injuries. A lot of people in Africa still believe that accidents don't just happen, that when accidents happen, it must be that there are some spiritual factors that have contributed to the accident. And they believe that for us who are orthodox practitioners, we are unable to actually take care of the spiritual component of the injuries. So many of them actually discharge from the hospitals to go to the traditional Bonesetters so that the spiritual part of the injuries can actually be resolved. Next slide. And so you then have another category of patients who from the scene of the accident would present to the traditional Bonesetters, okay? Now, again, quite a large number of them, when they present to the traditional Bonesetters within the first 6 hours. But if you look at the duration of stay, all right, whereas if they present first to the conventional hospitals, within 3 days, they are completely dissatisfied and they want to get discharged. But when they present to the traditional Bonesetters, you can see that they give the traditional Bonesetters as much as up to 190 weeks. Okay, that is over a year, all right? With a mean of 37 weeks, they stay there before they actually leave them, all right? Okay, and even when they leave, 20% of them still don't go to the conventional hospitals. Okay, 20% of them would rather exchange one traditional bone home with another traditional bone home. If you juxtapose this and you compare it to the previous slide, you will then understand what I am saying. Whereas within the first 3 days, they are completely dissatisfied with our care and they want to go to the traditional Bonesetters. In this instance, some of them stay as much as 190 weeks, a mean of about 37.4 weeks before they get dissatisfied, okay? And when they now finally leave the traditional bone homes, why do they leave? Okay, in 47% of cases, they are eventually not satisfied with the care that they got, all right? In 28% of cases, it's because the traditional Bonesetters tells them that the care is complete, even when the fracture has not healed, or even when more complication has been created, okay? They then tell them that, look, your care is complete, you have to go home, the rest of the healing will take place at home. In 10% of cases, it is because in the traditional home, they have developed emergency complications. And these complications vary. They include things like gangrene, okay? The limb becomes gangrenous, and then the traditional setters finds a way of pushing them out. Some of them will develop tetanus, okay? And some of them will develop other severe complications. And then it's only in 7%. If you compare that to what happens when they present to the hospital, it's only in 7% of cases that the families and friends try to pressurize them to leave the traditional homes. And this tells you the kind of belief system that people have in these guys in these parts of the country, of the world. Next slide, please. Okay. And so when you ask patients generally, those who have gone to traditional homes, why have they gone to traditional homes? Some of them say it's because the traditional care givers are cheaper, but facts have proven that that is not correct. What is correct is that for the traditional bone setters, they are happy to collect feeds in bits and pieces, okay? If what you have is 50 cents, they're happy to take the 50 cents. And then if you come with $1 the next day, they're happy to take the $1, okay? Unlike in conventional hospitals where they give you a bill and they expect you to pay the full bill or a substantial part of the full bill, okay? And then of course, in the traditional homes too, they are happy to take, to ensure that they're happy to accept non-cash payments. And what do I mean by non-cash payments? If you have clothes, you can take clothes to them. If you have animals like chicken and all the rest of them, or goats or whatever, you can take it to them. They're happy to take it and convert it to cash for you, okay? Of course, that won't take place in the hospitals, all right? And then, of course, you have pressure from family and friends, all right? And quite a number of them erroneously believe that with the traditional bone setters, particularly because the traditional bone setters will sort out the spiritual aspect of the injury anyway, that there is faster healing, okay? And then quite a number of the patients believe that the major care that we give in conventional hospitals are actually amputations and all the rest of them, which is not true, okay? And then as a result of delay or lack of accessibility, some of these patrons actually go to traditional bone setters. So these are the reasons in our environment why these guys choose to ignore orthodox hospitals, choose to ignore trained orthopedic surgeons, and prefer to actually access trauma care from the traditional homes. Next slide. Okay, so this essentially shows the pattern of injuries that presents to the traditional homes. You can see that it's virtually all the bones of the body. Okay, sometimes it's basically soft tissue, right? The most affected bone is actually the tibia and the humerus rather, okay? And then of course the tibia and the femur, all right? Next slide. Okay, so what are the types of treatment? The mode of treatment that are offered by the traditional bone setters, okay? In majority of instances, almost half of the cases, okay, it's herbal massage. They prepared some herbal agents from leaves and some other sources, you know, form them into a paste and massage, use that to massage the bone. And I'm sure we all know the implications of that, okay? One of the most important factors in the healing of fracture is stability, okay? If there's no stability, you may not have healing, all right? And so when you then have a situation where a fractured bone is constantly every day being massaged and being moved around, it's not a surprise that one of the major challenges that they face is non-union, okay? And then the splintage, they have, I'm going to show you the picture of the typical type of splint that they use to hold these bones. The splint, when you see it, you will know that they do not follow the normal principles of fracture splintage, okay? And this splint, sometimes, in many instances, is actually the cause of some of the, this splint, in many instances, is actually the cause of some of the most deadly complications of traditional bone setters, because the splint can actually, in many instances, can be made too tight, okay? And when it is too tight, it compromises the blood supply, either the venous supply or the arterial supply or both, okay? And you see the kind of complications that they cause. And then, of course, constant manipulation of the fracture sites, okay? All of this contributes to non-union. And the scarification. Scarification is the use of blades to actually make marks on the body. And we have seen that sometimes this actually leads to tetanus, all right? And then, of course, the use of incantations and the rest of them. And in a very minority of cases, they actually try to mimic what happens in the typical hospital. They try to apply POP at birth very wrongly and sometimes very dangerously. And where there are wounds, they try to do some wound care, again, sometimes very dangerously and very wrong. So the next slide. Okay, and so it's not surprising if you see the kind of treatment that they offer, the kind of complications that presents to the hospitals is actually not surprising. Like I said, this is a study that was done some time ago. It's a series, okay? And you can see that virtually all the complications are present here, all right? You have things like malunion, which is the commonest, and non-union. The non-union is not surprising because the fracture is never given time to actually, there's no stability, okay? And so the non-union is not unexpected, okay? And then also because even the splint that they use does not give stability, malunion is also not unexpected, all right? And then, of course, you have things like avascular necrosis, right? And compartment syndrome, infection, chronic osteomyelitis, bony ankylosis, you know. These are some of the things that you see, all right? Wound infection, joint instability, because of the frequent and almost ceaseless massage, you have heterotropic calcification and gangrene and all of that. So these are the kind of complications that frequently presents from this guy. So next slide. So this is what the splint looks like. Okay, you can see the splint. You can see that this is not going to cause any fracture to be stable. All right, but it can also cause problems when it is too tight, and frequently it is too tight. All right, it compromises the distal blood supply, and that leads to gangrene, and gangrene leads to amputation, and that is one of the most feared complications that they cause. Okay, and this practice actually is one of the commonest causes of amputation in our environment. Next slide.
Dr. Dada, before we proceed, I just wanted to warn all of our presenters that some of the slides that will be presented by our panelists today will be a little bit graphic. So I think that now is a good point to mention that.
Yeah, yes, that's an important information. Thank you. So the next slide, you can see this limb. This is a patient, okay, who went to traditional Bonesetters. All right. Of course, it was the splint that was applied. The splint compromised the blood supply. And then you can see that the forearm bones virtually dead. Okay. And this patient can only benefit from one treatment, and that treatment is amputation. Okay. There's virtually nothing else you can do for this patient because the forearm is completely dead. So the next slide. Again, this is another complication. All right. Okay. The forearm, you can see the forearm bones. You can see that there's in fact nothing that you can call the forearm again. All right. Again, this patient can only benefit from amputation. And this has been caused by a proximal splint, the type of splint I showed you earlier on, okay, that had been applied very tightly, has compromised both the arterial and the venous supply, and then you have gangrene. Next slide. Again, you can see this. All right. This patient actually came straight, I think after almost 1 or 2 weeks from the traditional Bonesetters and presented to us. Okay. The whole of the muscles of the leg were completely dead. Okay. And there was nothing else one can do for this patient other than to offer him amputation. Again, it is as a result of proximal splintage of the fractures. All right. So next slide. Okay. And so when they come to us, we still try all of our best to see how we can help them. Okay. And in this particular series, we were able to treat about just a little bit above half of them. We offered them surgery. Okay. We couldn't do much for about 24%, so that they developed severe ankylosis, okay, or some other complications that we need to do like a benefit risk analysis and find out that maybe intervening surgically would not yield much, all right? And then unfortunately we lost some to follow up. So next slide. So what do we offer them when they come? Okay, all right. Many of them, we don't have any other option but to offer them amputation because the limb is either necrotic dead, gangrenous, okay. For some, we are still able to do external fixation. A few of them, we take care of the infection. We allow the inflammatory reactions to settle down, okay, and then we do open reduction and internal fixations for them. And I must tell you, I must warn you that particularly for some of them who have non-union and who have my-union, is particularly a very dangerous operation, okay, because you have a lot of bleeding. Some of these people might have had my-union for 3-4 years, okay, so you have to force to stotomize the bone, all right. Some of the bone the ends of the bone, of course, may not have good blood supply, and that may lead to shortening and other things that may actually need a bone lengthening subsequently. So it's usually very complex procedures that we offer these patients, okay? And of course, some of them, the only thing you can offer them is physiotherapy to improve the range of motion, okay? Because you, like I said earlier on, you actually need to weigh these patients and see that they would actually benefit from further surgeries, okay? And where they can benefit from further surgeries and they can only benefit from physio, you offer them the physio. And then, of course, sometimes you are still able to give them POP, and occasionally all that they need is wound care. Next patient, next slides, please. So in conclusion, this is the challenge that one of the biggest challenges that the average orthopedic surgeon in any part of Africa face, okay? It's sometimes quite tough. It's based on their belief system. We try as much as possible to help them when they come. Quite a number of my colleagues have tried to see if it's possible to actually train these guys, okay? At least let them be able to identify their practices that are dangerous. Let them be able to identify also those cases that they cannot handle so that they can refer them early. Some of my colleagues in their publications have reported some sort of improvement in the practice of those categories of bone setters that they have treated. Some have reported no improvement, but I think personally that it's better to train them, okay, because they are widespread and they are really in the interior and in the villages. It's best to train them so that they can do less harm and they can cause less havoc. Thank you very much.
Thank you, Dr. Dada. That was a fantastic presentation, a really good introduction as well.
Yeah, thank you so much, Dr. Dada. Very insightful and enlightening talk. And I gotta say, my team in our work in Tanzania, we referenced your work a lot in designing our projects. Got another member of our team here, Dr. Octavian Sharima. We found a lot of similarities to what you found in Nigeria as far as the herbal massage, the kind of splinting that was used, and the cash payments were actually pretty equivocal between the traditional bone setters and the orthopedic surgeons, which was surprising. But then we also found that a lot of them were willing to take cows and goats, especially those of part of the Maasai tribe, which is a primarily pastoralist tribe. One thing I thought that was really surprising about your work is the fact that people from all kinds of levels of society patronize these individuals, which, you know, certainly complicates educational initiatives to improve, just, you know, make people aware of the complications that can exist. So thank you so much. All right, next we have Dr. Diallo from Burkina Faso.
Well, Liz, let's give Mengistu another try. I think that he's got his computer working now. Yeah. Mengistu, do you want to give it a try?
Yes, Kiran. Can you try for me, please? So thank you very much, everybody. It is my pleasure to be in this panel discussion. I'm Mengistu from Hawassa, Ethiopia. And I would like to thank Harvard Global Orthopedic Collaborative to invite me to present our initiative on this bone setter associated issue. Ethiopia is one of the countries in which these bone setter associated complications are very paramount. So we have a study which is called a bone setter associated disability. In short, it is called a BOSAD study. It is a national type of study. So my talk will be more of on BOSAD study. I'm sure I will cover the topic that's given for me. So next slide, please. So I don't have any disclosure to present. So next slide. So to map my presentation, I will use this outline. I will have a short background session. I will try to show the magnitude of the problem in Ethiopia, and I will also present the rationale of the study. And finally, I will present way forward and will summarize. Next slide. So as a background, I'm sure those presenters who present before me, they mentioned like this Bonesetter practice is really, it is dates back to the ancient time. In the Egyptian time, even in the Egypt, it was one of the treatment for bone and joint associated conditions, and it is really deeply rooted in the community. That is one of the things that we see here in Ethiopia as well. So they were main provider of the care, and they use different wooden materials like bamboo, as you see from this picture, and they are also using some carton, leaf, and tight bandage. And their practice is really associated with many complications from limb endangering as well as anti-life endangering issues. So next slide. This is another picture which shows how they use locally prepared towel in order to spilling, but at the end of the day, it will be complicated with tight dressing. Next slide. So when I came to the magnitude of the problem, as I tried to mention, this practice was really there in every country in the ancient time, but with time, it is obsolete in the Western, but it is really common in low and middle income countries. There are a lot of complications reported as well as unreported. Some of the patients presented to us, and other patients will stay in their home. That is the thing that we see from our research. So the practice is really worse in Nigeria, Kenya, Ghana, and Ethiopia. I'm sure other presenters were mentioning their own condition. So I will also focus on Ethiopian practice. So in Ethiopia, for the last 2 years in Hawassa, specifically where I'm working, we did 39 amputation due to traditional Bonesetter related complications, specifically gangrene. So it accounts 17.9% of total amputations that we did for the last 2 years. And the bad thing is, it is 92% of the amputation is occur in pediatric patients, which means they will not decide for their management options. They will be taken by their family to traditional Bonesetter and get complicated. So we have also 3 diseases with this time. 2 were due to systemic septicemia, and 1 patient, young patient with open fracture, was treated with a Bonesetter and get complicated with tetanus. So these 2 we have 3 days, and there are also a lot of limb disabling complications. Next slide, please. So this is the first index case that I see when I was when we start working in Hawassa. This is a 14-year-old kid who sustains femur injury, physical injury, and he was taken to traditional Bonesetter. So they apply tight bandage, and as you see from the picture, his leg until the mid, almost above the knee, above the fracture site, is completely, it developed weight gangrene, and there was a single tag of skin which connects the weight gangrene limb, the leg and the foot, with that of the thigh. So when we transfer him from his bed to the coach to transfer to operation theater, this weight gangrene was just, his leg was fall down in front of us, which is really heartbreaking news. Next, please. So we have a lot of complication, like this guy, he has distal fracture with distal joint dissociation, for which he visited traditional Bonesetter and he developed this deformity with non-union. So he's waiting operation in our center. Next slide, please. This is another kid who have isolated ulnar fracture, which could be managed non-operatively. He was taken traditional Bonesetter and presented with missed compartment like this. Next, please. We have this patient who presents very late, actually, once he developed Volkmann ischemic contracture. Next. This is another patient who was having just fall down accident from standing height and getting injured to her hand. She was not having anything, but she was taken to traditional Bonesetter and she get massaged. As you see, she presented to us with skeletonized radioulnar bone, which was 100% preventable. Next slide. So to see some of the data, this is the data from Nigeria, Ghana, Ethiopia. We have 2 studies previously done study, and we have also the pilot study. Next, touch it one, please. So I will mainly focus on this Ethiopian perspective. So if you see the publication from 2013 and now, even though it is not published, we are processing to publish the BOSAR pilot study. If you see the prevalence of traditional bone setter as a first sport, it is 56.9%, which is 57%. But now, even though the number of orthopedic surgeons increased, the community, most of the population visit traditional bone setter as first part of their management in 89%, and most of them they are presented with complication, almost all. And the joint stiffness is increasing from 53 to 67%. Infection rate is also increasing. Non-union and volcamascenic contracture is also increased from around 6% to 14%. And if you see the amputation rate, in 2013 in Ethiopia, it was reported, actually it is a single institution report, it was reported like it was 4.3%, but now it is 17.9%. And the malunion rate is also, it is equivalent. So the whole point that we learn from this table is, even though the number of orthopedic surgeons increased, there is still most of the patients didn't get the orthodox approach of musculoskeletal trauma, rather they will go and visit traditional bone setter. Next, please. So this is one of our patients, 9 years old kid who end up with amputation secondary to bamboo splint with traditional bone setter for simple distal humerus fracture. Even he didn't come to us, it can be healed and it would be possible to remodel, but due to a traditional bone setter complication, he lost his arm and hand and forearm, as you see. Next. Another patient with spiral humeral fracture, 7 years old kid. Again, it is a type of genuine fracture which could be managed non-operatively anywhere, and remodeling chance is high, but due to traditional bone setter type bamboo splint, he ended up with amputation. As you see, he developed weight gangrene. Next. Another lady, which is a really a lady kid, which is really heartbreaking. She is 8 years old kid, school student, and she lives with her stepfather. She was sustaining falling down accident while she played. It was closed injury and it was supracondylar fracture. She was taken to traditional bone setter and she comes with this skeletonized humerus and she was having weight gangrene just to the edge of days. So we did amputation. This is her picture shows that. On the next picture, her picture shows that she's really happy at 6 weeks. The reason why she laughed is, or why she smiled is, it was really painful. It was really devastating while she was alone. Only her and God knows what was happening there. She was vomiting, she was toxic. So due to that reason, even though she has amputation, even though she's disabled compared with her friends, she seems happy, which is a very heartbreaking again. Next slide, please. So in general, after saying this, after showing this old picture, the rationale for why we are interested to do this study is we need to have we realize that we need to have urgent need of solution to prevent this pediatric amputation in the days. It is completely preventable amputation as well as the disease preventable if they get appropriate treatment. And we believe like there is a paradoxical relationship of number of orthopedic surgeons and bone setter associated disability. So even though the number of orthopedic surgeons is increasing, as repeatedly mentioned, but still we can't prevent the bone setter associated disability. That's why we need to do this study. Next slide. So way forward, we're designing a national web-based study to collect data, and we're also applying for international studies, including Ghana. So the aim of this study is to identify the real gap. It is most of them may be known, but we need to have a nationwide study, if possible international study, and every gap should be identified and appropriate measures should be taken for that. The other thing is we need to develop a protocol. One of the reasons why patients is taken to traditional bone setter is those health professionals working at low and middle level in the health tier system have a knowledge gap in the management of musculoskeletal injury. So we need to develop protocol and we need to give training for them. The other most important thing, everybody should practice under scope of practice. So we are planning to prepare the scope of practice for bone setters. So they need to be responsible for their action. That's the most important thing. And lastly, we need to alarm stakeholders. Different stakeholders are busy in managing different things and they ignore these things. So we need to show the magnitude of the problem and we need to get their responsibility to this thing. Next slide, please. So this is just to give an overview of, we have, this is a web-based study. Anybody who are interested to see, now you can get bonesettersstudy.com on Google. So for the time being, for the coming 5 days, it is on development with our software engineers and advisors. So this is the Bonesetters Disability Study website. This is a photo gallery, that's different thing. Next, please. We will upload photos. This is a photo gallery, different picture of a patient in which we get consent to post on the website will be posted here. Next, please. This is my team, the national lead of the study. So just to show for next, please. So here we write something about what we are doing. That's introduction. We write the object of the study, vision and vision. Anybody who are interested, he can or she can get it. And this is anybody who want to contact us, they can contact us. Next, please. So this is for the data collection. We need to log in. And finally, this is the variables that we collect. So data, injury data, presentation data, completion, treatment data, and research question. Next, please. Yeah, we can upload X-ray of patient, we can upload the picture of patient in the website so that for further analysis, we can use it. Next, please. Finally, in summary, I will summarize my presentation with this Bonesetters logo. So in general, we all are saying no more disability should be accepted from traditional bone setting. Anybody doesn't deserve to have amputation or death due to simple musculoskeletal trauma. So this is our motto, and I hope everybody will agree with this point. Thank you very much.
Thank you
very
so much. Oh, go ahead,
ahead.
Kiran.
No, please.
Thank you so much, Dr. Gebreyohanes. That is a really exciting study that you have going on. It's especially tragic when pediatric patients are the ones that are impacted by this, given they have no say in their care and have the biggest futures ahead of them. So I'm really looking forward to see the results of this study. Something of this scope hasn't been done before, and depending on what you find, it can really have impacts for not only Ethiopia, but East Africa and West Africa as well. So very excited to see about that. And next, we can move on to Dr. Diallo. He will have some cases for us to present, or for him to present.
Good morning, everybody. I would like first to thank all the Harvard Global Orthopaedic Collaborative team to invite me for this webinar. Traditional bone setting is very common in our daily practice. It is something prior European colonization has some root in our country. We had to deal with them every day. When I start in Bobo Dioulasso, is in Burkina Faso, West Africa, 3/4 of our emergency patients refuse our modern care and choose to go to traditional care. Now, 8 years later, the percentage dropped to less than 1/4. The most common complication we had is related to open leg fractures. Among gangrenes, non-union, malunion injuries we received, I choose to focus to highlight 2 cases, one with a good outcome and another with a bad outcome. Slide, please. Slide, please. The first case I would like to show, it's a male patient we received some hours after a motorcycle accident. It's very common in my country. He sustained a knee pain. Firstly, he chose to go to bone setting. They do massage, mixture application, and some splitting. Slide. He was not satisfied, and when he came to us, we found a minimally displaced tibial plateau fracture. So we treated non-operatively. Slide. And we had a good outcome with bone healing, no knee stiffness, and no thrombosis. Okay. Case 2, slide please. The second case is a young girl, around 5 years old. She falls from a picking fruit on around 4 or 5 meters, and she's sustaining elbow pain and swelling. They do massage, mixture application, and they put a tourniquet at his arm. Slide. When she came to us, after a bad evolution, it was a gangrene, and we have to do amputation right at his shoulder. Slide. He died in a sepsis situation. Slide. These two cases, slide, please. These two cases allow us to focus some question. The first question is why the patient or his family choose traditional ball setting prior the hospital. Here we don't have to, in our practice, the patient is not a man or a female individual, it's a family. The choice not related only to the patient, is society, they decide together. Sometimes the person who have to decide is not the patient, it's an uncle, a father, or someone who had economical power in his family. So they choose to go purely to traditional bone setting because they believe in it. And sometimes because of the price, they are afraid of modern trauma care. Also, we think it's somewhere the condition we work is not sometimes not the things they're expecting. And secondly, they come to us because they don't have satisfaction, bad evolution, or something goes wrong in the first care. And sometimes we have to do some debridement and not very, very, the surgery we have to realize are sometimes amputation, debridement, not very, and it's a bad, and the outcome is sometimes bad. Even if the patient come to us early and you put a cast or a splinting, they choose to go to bone setting. It's a deep sociological problem. Next slide. These two cases allow us to focus some point. The first point is the belief and culture. Not only related to poverty, people believe strongly in this person because they mix, how can I say, sense and something like mysticism in their care. And we don't, and in our medical schools, we don't, we tried now to understand the way the patient had confidence in them. It's something in modern care is not very, it's something we fail to achieve. And secondly, we don't have health insurance. So patients come in hospital, they take time, they have to look for money, family have to find money for surgery. This is something that allow some people to transfer them from hospital to Bonesetters. It's something we have to work on that. And second, and thirdly, we don't have enough trauma facility care, and this induce a large delay to care, and the cost is also important. Also, fourthly, in my country, they develop a policy in traditional bone setting. It's very difficult to understand because it is they have authorization sometimes to practice, and people, they don't, if they have problems, you are not, it's not easy to go to trial with them. It's something we need to clarify. Slide. The conclusion about my two cases is we have to do our best to avoid the bad outcome. And this, in my opinion, is to develop insurance, health insurance, and to improve our modern care quality, to give confidence to people. And we have to understand the sociology. If you don't understand the sociology of your patient, you might have the better, how can I say that, you can everything you want to do, if they don't understand what you try to achieve, you cannot get compliance from them. Thank you. I would like to excuse, I'm coming from French-speaking country, so I have to try to be fluent in English. It's not easy. Thank you.
It was fantastic, Malick. Thank you. Very well understood. Excellent cases.
Yes, perfect English. Thank you so much for sharing kind of a negative and a positive outcome from these complications that come into your hospital. And you also brought up a really interesting point, kind of the healthcare policies surrounding the legality of practicing this can really impact kind of the result of collaboration. I know in Tanzania, traditional healing for a long time was outlawed due to a traditional healer-led revolution against colonial rule. And for a long time, that really made it difficult to kind of keep tabs on what was being done, and still has some negative repercussions on trying to gain trust of this group now.
I think that's really a very interesting point. It's like if you try to eradicate Bonesetters in aggressive ways like that, it's hard actually to do so, because as Malick just mentioned, the sociocultural relevance of traditional bone setting in many countries, as we've just heard, is really profound. And so if you try to eradicate it through government processes like that, it's very difficult. Whereas if you incorporate them into you have elements of regulation, perhaps that's a more effective method. And I think some of our speakers will talk to that. Dr. Ndasi, are you ready to present?
Yes, I am. Okay, good afternoon, everyone. It's a pleasure for me to be part of this, and my presentation has already been partially presented by Dr. Dada, as well as Mengistu, because we have quite similar issues that we are talking about. And Dr. Dada mentioned most of the initial things I want to talk about, so I'll just rush over them rather than repeating them. But in terms of fracture healing and the traditional bone setter, we will all agree that, as he said, this is inbuilt in tradition in the African setting or in general settings. And so it is often common to look at them like rudimentary practice or unacceptable practice, which may not be fair. This is practice that has always been, but with science, we have seen the limitations and we are trying to improve on them. And so this is a practice that has that would not be eradicated any soon. And again, I think the traditional bone setters or healers are just working on taking advantage of what will normally happen. As we know, most fractures would heal regardless of what you do if the bones are touching each other, especially the close fractures. And that is the same principle which we are teaching in the non-operative management of fractures. The only difference is we try to improve on alignment, range of motion after, or splinting without creating a compartment syndrome. And so once we have this practice or this situation of the human body having its natural way to work, those who even don't do it well will take advantage of it and say that's what they did, when that bone would have equally healed by itself. So that is one factor about it. And in my opinion, we should also be careful of deriding the actions of traditional bone healers, because once any of us in the medical field or orthopedic surgeons talk about traditional bone setters, the only attempt is often to see what wrong they are doing. So my presentation, I'll shift a bit from what has been presented to look at what is the cause of this. And I think the traditional bone setters are just filling a void in our healthcare structure and systems. Because, as the other speakers mentioned, there is an inherent deficiency in our health systems. We don't have adequate medical professionals or orthopedic surgeons to take care of some of these bone setters. It is true, we are having more orthopedic surgeons, and in one study in Ethiopia, they said they didn't see a gap initially, but I'm sure he mentioned once they had more orthopedic surgeons, only 1/4 of those patients continued to go to the bone setters. It therefore means that our healthcare systems are not training or developing enough manpower to close this gap or this void that has been created and the traditional bone setters are taking advantage of. I believe all human beings, both the traditional bone setters, even the patients themselves, want a good outcome for their injury. And I don't think the traditional bone setter would want to create a complication from the injury that comes to him for management. But I'm sure limitations in understanding of the nature of the fracture and also the patient's orientation about treatment of a fracture is what is bringing about these complications that we are seeing. So if both parties all want a good outcome of their injury, why then do we keep having these problems? And so I think that these problems are due to, one, lack of adequate education. These traditional bone setters don't know their limitations. They don't understand periarticular injuries. They don't understand compartment syndrome. And therefore, I agree with some of the presenters who said maybe we should not just deride the traditional bone setters or see them as in conflict with orthopedic surgeons and try to make laws to wipe them out, which will not succeed, but rather have some bit of meaningful education to give them. We cannot, of course, train them to become orthopedic surgeons. It is something more complex. But I'm sure we should start by trying to educate them about the complications. When a child keeps crying, don't say, no, the treatment is working. Rather, try to raise an alarm that there is a problem. I got a little experience about getting traditional bone setters involved when I was doing the clubfoot care advocacy. In one part of the country where we're treating clubfoot, we noticed that there was a lot of clubfoot in this area, but we're not having most of the children come. So out of what we usually do, we had on this World Clubfoot Day on the 3rd of June, we decided to also invite traditional leaders and some traditional bone setters in that community. And they gladly came. So we talked about clubfoot treatment, the Bonesetters technique, how it is more effective than doing splinting and all of that. And suddenly there was a jump in the presentation of clubfoot cases in that community. So we did not go to them to deride them from the way they were treating, but we educated them. And some of them, or those who came, saw that these children could be better managed with POP rather than what they were doing with bandages. We weren't like competing treatment with them. So through that, I thought that was something that was an eye-opener. We did not expect that, but we knew because most of the patients that came late had gone to some traditional healer or bone setter. Maybe if we got to talk with them, they could allow those children to come to the hospitals earlier. So this is a classic example of education and its impact. Education, rather than seeing a situation of trying to wipe out a traditional practice that has a lot of confidence in that community, will not work. And as Dr. Dada said, the financial aspect is also there. Most of our patients don't have any form of healthcare insurance. In fact, many of our people are living on a borderline financial situation. So when there is any disaster or accident, they need the family support system to help them. In that situation, they will not have that bulk of money to present to a medical facility. But in a traditional bone setting, they can pay in cash or in kind and in bits. And they don't even need to travel very far most of the time. It is in their community. So they have confidence in that, compared to going to a big town to see an orthopedic surgeon that you need to queue for hours, to see him in an office only at specific hours of the day, in a town you don't even know. That is already a limitation or a limiting factor for patients attending healthcare. Also, in some of the slides which I'll present, I think you can go to the next slide. So I'm talking about the weaknesses in our healthcare system. Now, in some of these slides that I'll present, this is a distal humerus fracture. This fracture could heal if you even do nothing. Now, there are two things that could happen. This particular patient could go to a traditional bone healer and they tie a very tight splint, and this child will have a distal arm necrosis, just like what the other presenters have said. At the same time, this patient could also go to have surgery. Now, in our countries, we have, like in Cameroon, we have one medical school that is training orthopedic surgeons. My team in my hospital, we have 4 orthopedic surgeons, and none of us were trained in the country. It therefore means that the country is not training enough orthopedic surgeons to manage its own population. You therefore do not have enough trained personnel. If they don't go to traditional bone doctors, where would they go to? The surgeons are not there. And so in this case, I don't need surgeon treated on this patient, but if a patient even goes to a hospital setting and has the wrong treatment or has a treatment that fails, that becomes a demotivating factor for him and other patients in the community to go to the hospital. So this is a fracture that was fixed in that hospital for that fracture. And if you look at this fracture, any orthopedic surgeon will know that this is a disaster waiting to happen. There is already a problem with the implant and the nature of fixation. Next slide. And so the disaster happens. So this patient comes with a fracture that will have almost similar outcomes if treated non-operatively and if treated operatively by the right methods and techniques. If this patient subsequently develops another fracture, how do you think he will go again to the hospital to spend the limited resources he has? Of course, this is an isolated incident, but this is a typical example of what happens. This patient had the wrong implant, wrong incision, and the wrong number of plates. Okay, so this particular patient has a bad story to tell because he even went to what we're advocating, go to the hospital to have the right treatment. This patient went to the hospital and did not have the right treatment. Next slide. This is also another case, spine injury, or I think it was maybe a spine fusion that this particular surgeon wanted to do. Spine surgery is a high-end surgery that you need the right form of implants. In a healthcare system, how many spine surgeons do we have? How many centers can afford the right implant for spine surgery? But you have a big population having spine injuries or requiring spine surgery. And we may also deride this surgeon for doing this. Was he doing the best of a bad situation by using the wrong plate, wrong approach, everything wrong about this in order to salvage this patient? You could defend it both ways. Or was it just because of commercial interest? So in this situation, we have bad procedures, bad intentions, everything bad in a setting which we think should be the right thing. And patients come with bad outcomes. And so they will go back to depend on their traditional method. Because in this situation, this patient will continue to have pain. He will require another surgery for the removal of this implant, and the pain remains. The same patient or the same situation may have presented in a traditional bone setting. And this patient will have massage, which, as we know, most spine or back pain may resolve over time. And the outcomes may almost be the same between those who were operated and those who were not operated. This patient will have a non-operative method by massage and gets better over 3 years. This particular patient who had surgery will not get better over 3 years. That reinforces the community's confidence in the traditional bone setters, because our healthcare system is not providing the right training, the right equipment to provide standard care as we think we should advocate. So we are in a context where we are advocating the right things, but without facilitating or providing the right facilities for that right level of care to be provided. Next slide. So, like the others, these are 2 injuries, and we have similar spleens as those of Nigeria and Ethiopia. And these 2 fractures, the tibia could have healed. Because as we also know, if for any reason we could immobilize the fracture appropriately, it's going to heal. The femur fracture may not heal, because of the amount of soft tissue around it. Now, in both situations, they may be lucky that the splint here was not too tight. But these patients have also suffered from the same consequence like the other patients we're talking about. They all have a non-union. Now, this patient comes with a non-union. I don't have the pictures of that, but we keep seeing patients being managed with femur plates, which we know is not standard of care. In that environment, we are lucky to have the sine nail. And the sine nail provides the best fixation we see commonly in most of our long bone fractures. But again, in other settings where they can't afford the nails, they keep using plates, which are prone to failure. That makes patients to lose confidence in orthodox care. Next slide. Again, this is a similar picture like that Mengistu presented, a distal humerus fracture that heals and the patient comes with deformity. And again, once the patient comes with deformity to the hospital, it is more difficult to manage. And so the surgeon managing it must be very careful, because if he doesn't produce a better outcome, they will say, I told you the hospital will not do better. And nobody will understand that this patient came to the hospital with an already difficult situation. Next slide. Now, again, this is one of the other downside of the traditional methods of treatment. We've had similar slides like this, so I don't need to re-emphasize this. Next slide. Again, this child's hand, of course, was amputated for similar reason. So we have this situation and we see this over and over again. How do we come out of this? Like our orthodox care, there must be some form of organizational legislation. And it all has to do with good governance, the right training, and the right healthcare system. All of this work together, and we can't do any of this in isolation. To have this problem handled involves all stakeholders, because if the right thing is being done, I'm sure these patients or the parents of this child want the best for their child. This was not their intention. The traditional bone healer also was doing the best he could. The surgeons who treat femur fractures with plates wanted to really provide the best treatment, but they don't have the implants. And so they are using what they have. Now, they are using what they have, which may be inadequate or low grade. The patients whom they also treat sometimes can't afford the right implant. And so maybe they use whatever they get. The governance system does not provide health insurance. And so the population cannot afford, even all the facilities cannot afford the right implant. My hospital, if we were to charge patients for the implants or the equipment we use, they could not afford. But like a few of us are beneficiaries of donations from kind-hearted individuals. That takes over some of the cost burden that the hospital would have put on those patients. So this does not apply in all hospitals. How many of those patients can we treat? Very few of them. So the take-home message is that until healthcare systems are strengthened through good governance, and then are also made more accessible and affordable, traditional treatment will continue to thrive and its own complications. And good governance will also help with appropriate legislation. Governments must devote more resources to healthcare. Healthcare is not just one of those things you think about. Healthcare education is equally as important like security and the military. So it is something that it is not left for the doctors, the Bonesetters, but it's something about governance. And that is where education is very important of all of us, especially women and girls, because when parents discover that even though I have this pressure to do this, it is cheaper in the long term to have the right treatment, even though it may look expensive, than resorting to meet treatment modalities that have no accountability. Thank you very much.
Thank you, Henry. That was a really excellent presentation. I think you highlighted a very important point about how building orthopedic capacity itself can improve the treatment of these patients, just because, you know, when you have poor orthopedic care and inaccessibility of good quality orthopedic care, patients will go to traditional bone setters. You know, so I think that was a very well taken point. Thank you very much for that presentation. I just want to say we're running a little bit late here, mainly because I just don't want to interrupt all the fantastic presentations that are going. But what we will do is just go a little later. So for those of you who can continue to join us, please do. Liz, go ahead, take the mic.
Thank you so much, Dr. Ndasi. That is an incredible perspective and such a well thought out perspective, taking into account all the different parts. The power of bad results from surgery is so strong on the confidence of the community. So thank you so much for bringing up that additional factor. And I just wanted to comment briefly on the World Club Foot Day educational training where you brought in the Ponzetti technique. That is really fascinating that you did that, and thank you so much for doing that. And I think that this kind of embodies the fact that when you even just bridge that divide a little bit, see someone face to face and start that conversation, you can make a lot of headway. And a lot of these guys probably do want education and do really, really appreciate someone from a hospital reaching forward and giving them some training. I know from the work that we did in Tanzania, we interviewed a couple of bone setters, and all of them said they wanted training. One of them had received training and was actually incorporating some sterile technique that he had learned from the training, but they all wanted something, but nothing had been done. So thank you so much for that work. So next, we will have Dr. Onyemaechi.
Yes, thank you so much. Can I go ahead to share my screen?
Yes, please do.
Okay, I'd like to start by thanking the organizers of this webinar for inviting me. I think this is a very important topic that deserves a lot of discussions, and I'm happy with the robust and very informative and very educative discussions we have had so far. Before I go on, I would like to say that my presentation will be a little bit different from what we've been hearing all the while. We've established these problems in my environment, in my own institution, and we have tried to take one step forward in trying to see how we can solve these problems. So I will be sharing with us some of the things we have done so far to try to solve some of these problems. Permit me to also, this is where I work, University of Nigerian Teaching Hospital in Enugu, Southeast Nigeria. Permit me to also, I'll try to follow this outline in my presentation. I'll share a little bit of my background. Please, I'll take just a minute to do this. I graduated from medical school in 1998. I had my training in orthopedic surgery and traumatology 2008. I've had some subspecialty trainings in pediatric orthopedics at the University of Hong Kong. I did the AO Trauma Fellowship in 2012 in Austria. I also had the SICO Fellowship in arthroplasty. In 2017, I got the American Association of Orthopedic Surgeries International Scholars Award and had some clinical observership at Columbia University Medical Center. I presently work as an orthopedic surgeon at the Teaching Hospital of the University of Nigeria. I also lecture in the College of Medicine. Presently, I head the Accident and Emergency Department, where I have both clinical and administrative responsibilities. My clinical practice is mainly of orthopedic surgery, trauma, consisting of deformities and also degenerative changes, inflammation, and all of that. I'd like to say that my interest in traditional bone setters TBS research started during residency. I saw while in training so many patients with deformities, with chronic bone infections and disability, limb gangrenes presenting to us as a result of traditional bone setters practice. Also, many patients with long bone fractures we observed would leave the hospital after the initial resuscitation and would leave the hospital against medical advice to go to the bone setters course. So far, we've published a few papers in various aspects of the bone setters problem in Nigeria. The first was in 2013, where we examined the attitude of health workers to this problem. We tried to talk about the complications of musculoskeletal injuries treated by Bonesetters in 2014. We also did a few other works. What are the reasons why people patronize TBS for short? That was published in 2015. And the last paper we did was last year, where we did a pilot study on trying to establish how feasible is it to train Bonesetters and see how we can integrate them into the primary healthcare system. That paper was published last year. So far, we've just completed a systematic review on the impact of the Bonesetters practice in contemporary fracture care in low and middle income countries. It's still being processed for possible publication. What are the current perspectives as regards Bonesetters care? It's important to know that they play a very important role in trauma care in Nigeria, as well as most LMICs. They provide up to 70 to 90% of primary fracture care to injured patients. This is quite significant. And, as already said by many of our earlier presenters, they enjoy high patronage and confidence in our society, and this cuts across social and educational strata, as earlier highlighted. One of these reasons is that there are strong sociocultural beliefs amongst our people, and many of them believe that the Bonesetters are actually better than the orthopedists. They also consider them cheaper and more accessible to them because they are closer to their homes. This is in the background of very severe shortage of orthopedic surgeons in Nigeria. Presently, just about 500 taking care of over 180 million people. This will give you a density of 0.27 orthopedic surgeons by 100,000 population. A lot needs to be done about this. All right, a lot has been said about their training, which is informal. They receive their training through apprenticeship from family members. Their care and treatment is getting more sophisticated with the use of X-rays, analgesic, and antibiotics, and some of them employ wound dressing and wound care methods. Because their treatment lacks, scientific basis, it's prone to complications. Some of these include very life-threatening and limb-threatening complications, as already alluded by earlier presenters. The overall impact of their treatment is generally found to be negative, and this reverses the gain the orthopedic fracture caregivers are trying to make in our subregion. The Bonesetters research is a well-researched subject. As you can see, all across West Africa and East Africa, so many people are doing a lot of work on Bonesetters care. However, there is a poor implementation of the research findings and recommendations, and this is the role that implementation science will play in trying to solve this problem. Some of the recommendations so far from different research works include: number one, improving access to modern orthopedic services. All right. Secondly, increasing universal health coverage, okay, with some form of health insurance. This is also said, if this can improve, the proponents of this recommendation believe that if you have, wide, access to healthcare, that the patronage of Bonesetters will actually drop. The third is that, training and also some form of micro-credentialing and regulation of their practice will help to curtail the complications. All right. And then lastly, is that the training of the Bonesetters and incorporating them into the primary health care can actually help to solve this problem. This is what we and our research team is trying to explore as part of the recommendations so far from the studies. It's also important to know that, my interest basically is actually to see how we can find some possible solutions to this Bonesetters problem, and then to see how we can promote the uptake of these research findings into evidence-based practices. Not just making recommendations and research papers published in good places. How can this translate to evidence-based practices to see how we can actually improve the outcome of trauma care in our region? We have some research infrastructure as already listed here. We have some partnerships, some government collaborators. We have a research team, and with some research support in my institution. We also consider that these people are critical stakeholders for us to work together to see how we can improve fracture care in our environment. The government plays a very important role. The attitude of the orthopedic surgeons themselves is also very critical. Okay, and then we need some form of collaboration with the Bonesetters themselves. If we continue to work at loggerheads, then there's no point. We are just working, as it were, parallel lines. They think they are better, than us. We think they are doing no work. So everybody's just doing their own job. and there's no meeting point. So we need to have some form of collaboration with them and see how we can, forge ahead. Now, engagement with government, as my team has tried to do. In 2018, there was a legislation that was passed in Enugu State, Southeast Nigeria, where I work, establishing traditional alternative medicine regulation board. We were happy when this bill was passed into law, and this will help in registering not just traditional bone setters, but all other practitioners of alternative medicine. Okay, we register them. Government knows where they are what they do, and that will provide some form of regulation of their practice. We were happy about this, but not much has done after this law has been passed. We have also undertaken some form of advocacy to the Director of Public Health in the state, who happens to play a very important role as regards the regulation of traditional bone setters care, and also to the Commission of Health, who is actually the person that oversees healthcare issues in the state. We've tried to engage with orthopedic surgeons. We did a survey of orthopedic surgeons in Nigeria. This was carried out in 2017 at the national annual meeting of Nigeria Orthopedic Association, all right, in Asaba, South Nigeria. We used a structured self-administered questionnaire, all right? And what were we looking at? The perception and attitude of orthopedic surgeons in Nigeria towards traditional bone setters practice in Nigeria, okay? There were, together about 84 respondents. All of them were males. These were some of the parameters: the age range, the mean age. These were the distribution of their different cadres, senior registrars, consultants, professors with the different years of practice. Okay. Now, this is their specialties. Majority of them were involved in general orthopedics and traumatology, and a few others were in arthroplasty, spine, pediatric orthopedics, and arthroscopy and sports medicine. All right. How have you treated? Have you treated patients with bone setters complication? Majority, about 95%, said yes. So this shows us that it is a common problem in our environment. Almost every orthopedic surgeon in Nigeria, has treated a whole lot of patients with complications from TBS care. All right, these are some of the common complications, as already mentioned by previous speakers. I won't bother going through them again, but for the sake of time. Now, we try to assess their attitude and how they view traditional bone setters practice in Nigeria. All right, we asked them, do you think bone setters provide primary care to majority of the patients? The majority agreed that they actually do. 64% agreed that majority of them actually, treat, fractures primarily. All right, we get to see most of the time complications that, result from their care. All right, but bone setters are filling a treatment gap created by social orthopedics. Majority also believe that this is true. We can now have about 500 orthopedic surgeons for close to 180 million people. It's a very serious shortage. All right. When we asked about their role in treatment of musculoskeletal injuries, you can see that up to 22% actually feel that they have a role to play. Up to 22% of orthopedic surgeons in Nigeria feel that they have a role to play. So this is a window that we can actually explore to see how we can expand, and see how we can train these people and bring them closer to orthodox practice. All right. Now, when we asked about how deleterious the outcome of their treatment is, majority agree that many of them do not believe that they only have deleterious outcomes. Okay, 47% disagree that their practice is only full of complications. 35% feel that they have some useful outcomes in their practice. All right. However, they believe that majority believe that they have common complications associated with their practice. All right. Now, does their practice, is it associated with good outcomes? 80% said no to that. Should government ban all the activities? Majority said, we think they should ban all the activities, but we have 39% who feel otherwise. Now, should they be given some form of training in modern orthopedic services? Half of the people who responded said yes, that we think they should receive some form of, modern orthopedic training. All right, and also majority feel that their practice should be regulated, and also they need to also be registered. Now, do they need to be incorporated into primary health care as a way forward in curbing the outcome of their problems? A majority of them, 44%, actually agree to this. And a little over half of the people were willing to actually offer training to bone setters. Now, we try to also engage the bone setters themselves. I must admit that this is a very hard task. If anybody has tried to do so, will agree with me that it's a very difficult task. The reason is very simple. There's a lot of suspicion. There's a lot of distrust. They see the orthopedic surgeons as competitors. All right. So when you try to engage with them, they first of all see you as you're coming to take away their business from them. So they are very, they are very resentful. All right. But we try to engage them through the public, through the government mediators. It's interesting when we try to engage them to notice that they actually have a very well-established regional and national leadership structure. They have an association, ASTRABON, Association of Traditional Bone Setters of Nigeria, which have state branches all across Nigeria. Many orthopedic surgeons may not know that they have very well-organized structure until you engage with them. All right. Now, our engagement with them was actually facilitated by the Director of Public Health in the State Ministry, who we actually met for the first time in his office. We held several meetings in his office, trying to build bridges and also to mobilize support from these members. This was a picture of our first interaction with them. Their leader is the man with the red cap, and then a whole number of their members were in attendance. You will also be surprised to see that a lot of females are also involved in this practice. Now, we tried to do a focus group discussion, which was facilitated by the public health physician in our team. 5 of them were involved, 5 TBS leaders were involved. And then we took some of their audio recordings. And the first thing we noticed was that they still claim superiority over orthodox practice. All right. I won't bother because of time to go through the quotes. All right. And also, secondly, they, however, admit shortcomings in their practice. They remember that they didn't go through formal education. Some of them are graduates from universities, tertiary education. So they know the limitations in their practice and they admit to some of these limitations. Okay, so this is also another window that we can actually use to penetrate into their practice. Many of them express desire for formal training. Many of them were very happy to have us engage with them to give them further education on how they can actually improve their practice. This was a very important finding for my team. All right, these are some of the goals which I won't go through because of time. This was the focus group discussion that we held in section. Now, having gathered all this information that they were willing to have some form of training, having also interacted with the orthopedic surgeons, we were able to articulate some of the critical areas that we feel that they need intervention. And we tried to do a pilot training using one of the very popular bone setters in the States, Mr. CJ. He was very popular, 43-year-old, with over 15 years of practical experience in bone setting. He had 2 apprentices and receives over more than 30 patients on daily basis. We had instructional trainings on patient selection, which was one of the key areas we identified, infection control protocols, and splinting techniques. Okay, these 3 areas we identified in our discussions to be the key areas that we need to train these people on to actually improve their practice. Okay, these were the pictures that were taken in the course of those trainings. We used one of his apprentices to demonstrate safe splinting of fractures, and the TBS himself and other apprentices looked on while the section lasted. Okay, we had a group photograph with both his apprentices and some of his patients at the end of the training section. It was quite a very instructional training, which they were happy to have. We planned to do some follow-up training for them, but because of the COVID lockdown, we were yet to do that follow-up training. What are the future possibilities? Number 1, we should try to improve access to modern orthopedic service. We should try to increase universal health coverage with some form of healthcare insurance for the members of the public. Training and micro-credentialing and regulation of their practice is very important. And I'm happy to announce that machinery is already in place in Enugu State where I practice, and we hope that that will yield a lot of fruitful results in our future research. And also training them and bringing them into the primary healthcare system, possibly as orthopedic technicians, is also one option that we can fully explore. The role of funding agencies, there's a huge gap in funding in bone setters research in Nigeria and other LMICs. This is a place where a lot of funding gap exists, and then we would be very happy to have some funding to actually take this training further. There are preliminary results that demonstrate there's feasibility and acceptability of traditional bone setters training in modern orthopedic care. And we strongly support that we should train them adequately and link them into the primary healthcare system in orthodox healthcare. However, funds are needed for this project to be driven. The next steps to build collaborative networks for Bonesetters researchers, which is one of the reasons I actually accepted to be in this panel. I'm happy to see a lot of researchers go in Nigeria and across Africa, presenting their research works. To share experiences, which is also what we're doing here, learn from our past failures if there are any, then advocacy is very critical to governments, establishments, to the Bonesetters themselves, building bridges and then seeking collaboration with them. We consider this as a very critical step. Funding opportunities, we should try to explore funding opportunities to actually, push our different research ideas forward. And then we support the idea that, we should train and link them to the modern orthopedic services. In conclusion, I must say that the Bonesetters have come to stay in Nigeria and many other low and middle income countries. They continue to contribute, provide primary care to so many patients in our environment. There's huge patronage driven by social cultural beliefs. That has been said by so many speakers. Treatment methods are prone to complications which increase our workload as orthopedic surgeons. We cannot continue to ignore them. We cannot continue to ignore them. We must engage with them. We must interact with them. We must provide some form of training for these practitioners. And preliminary results actually show that they are trainable, they are eager to learn, and this should actually, for this, we strongly advocate that we should train and link them to formal health sector. Thank you very much for your attention. I guess I'll be able to entertain questions at the end of this. Thank you very much.
Another fantastic presentation. Thank you so much, Dr. Onyemaechi. That was really interesting. I think you hit some of the very important points that have been covered by others and also highlighted the role of training, which is really fantastic. And I think Dr. Konadu-Yeboah will also touch on the same topic. So for the interest of time, I would like to invite Dr. Konadu-Yeboah to begin his presentation if he's still willing. Dr. Yeboah, I can share your slides if you like.
Yes, go ahead, please.
Okay, no problem.
Yeah, thank you. Yes, I'm Dr. Dominic, Konadu-Yeboah, orthopedic surgeon from Kumasi in Ghana. You're looking at traditional bone setting as a practice. I'm glad to be part of this panel. Next slide, please. Yes, most of the speakers across Africa have alluded to a common problem that exists in most parts of our continent. And Ghana, for that matter, is not exempt from these issues that have been raised by most of the previous speakers. Now, what we see in Ghana is similar. We have 52 orthopedic surgeons serving a population of 30.2 million people. So there is a depth of manpower to meet orthopedic care across the length and breadth of the country. And there is a huge gap between demand and supply. And this is an important factor that increases the patronage of traditional bone setters in most areas of the country, especially in rural areas. A study was done in northern Ghana recently, and it was found that within a period of 2 years, 32 pediatric limb amputations were performed as a result of TBS-related gangrene. So the problem is alarming, and there have been a number of interventions towards addressing this issue. I am part of the BOSA project that Mengistu spoke about, and it's a project we're trying to offer some form of training to these traditional bone setters on the basic principles of splintage and bandaging of fractured limbs. And we all know that most of the problems that are created by these traditional bone setters emanate from splinting, bandaging techniques that are inappropriate, that do not obey appropriate principles, and the fact that they attempt treating open fractures that tend to give infections. We have recorded a number of tetanus cases in our hospital in Kumasi as a result of open fractures being treated by these traditional bone setters. Next slide, please. So this is a case report. This was a 12-year-old boy who was knocked down by a motorbicycle in the Ashanti region of Ghana and had a fracture of the left tibia and fibular shaft, a closed fracture, was sent to a traditional bone setter, and this was the treatment that was administered. And as you can see, there was excessively tight bandaging of the limb, resulting in severe swelling of the foot. And you see in the next slide, the consequence of that when we remove the dressing. So as you can see, in this same patient, when the dressing was removed, this was what you saw. And you see, most of these herbs that they use, as you can see, are corrosive, and they tend to cause ulceration of the skin, and they convert a closed fracture to an open fracture, just as it happened in this case. As you can see, there is some ulceration on the anterior aspect of the leg, which did not exist at the time of the fracture. So the interesting thing is that these traditional bone setters are readily accessible in the communities by community members. They sound very convincing, and as it has already been mentioned, they are believed by community members to attend to both the fracture as well as the spiritual underpinning of the injury. Whereas in orthodox practice, we only treat physical injuries, but do not treat the spiritual aspect of the injuries. And they believe that every fracture happens due to a spiritual reason. Next slide, please. Yes. This was a 3-year-old girl who fell on the outstretched hand, had a very benign fracture, transverse undisplaced distal radial fracture on the left, and was sent to a traditional bone setter, and they applied hot water and performed excessive and a lot of massaging of the soft tissue. And 3 days later, this was what was brought to us in the hospital. And it's interesting to know that during the time of treatment, on the second day, the child cried excessively. The mother took the child back to the TBS, but the TBS reassured the parents that the pain that your child has is because the medicine is working and the child is going to get well. So these are some of the myths that we need to dispel so that we can improve their care. Next slide, please. So we have had a number of engagements over the past 2 years with these traditional bone setters. And as it has already been mentioned, the situation is similar in Ghana. You know, our engagements, before almost about 80% agree that they want to receive some form of formal training and they want to be licensed so that they can improve the work that they do. Among themselves, some of them think they know more than others. And when you show complications, they say that those were treated by poor TBSs, not the good ones. So among themselves, there is a lot of disparity in terms of competence level. So in our previous engagements, we have tried to train them using simple, easily accessible tools. And sometimes we're trying to use their own materials, the rafters that they use, to train them to see how we can probably design the rafters to obey the basic principles of fracture splintage and treatment. So as you can see, this was a cupboard that we tried to use to fashion to demonstrate that the fractured leg, as you can see, can be splintered safely using cupboard, whilst you transfer the patient to hospital if you have to. Next slide. Yes, we also designed these wooden slabs to demonstrate to the TBSs that if you elect to treat a fracture, you can use this material to splint the fracture instead of using rafters or bandaging only a small portion of the leg, occluding venous return and arterial supply. Next slide. Yes, so we visited this traditional bone setter. He practiced in a city in Kumasi, and it was interesting to know that this man was treating an open fracture of the left tibia. And we just wanted to have a feel of his work to understand how he treated his patients. And so, as you can see, he had applied the bandage to the limb previously with rafters. The rafters he used are the ones you can see on the floor. And the patient had an open fracture, and he was going to him on a daily basis for the dressing to be changed and some black concoctions in the blue bucket below. The content is not very obvious, but he was using the black concoction in the wound. You apply it to the wound before applying the bandage. And these are some of the practices that cause the terrible infections that we see. So some of them treat open fractures, and the number is not as negligible as you may think. Next, please. Yes. So similarly, this was a 5-year-old girl. This girl did not have a fracture. She had obstetric brachial plexus palsy at birth and had been living with it with some form of limitation of flexion of the rib, flexion of the wrist and flexion of the elbow. And the parents were advised that there was a TBS that could treat this birth injury. So this child was sent to the TBS. He applied some corrosive herbs, and 3 days later, the parents realized that the child was not getting well, crying excessively. So they brought this child to hospital. We exposed the limb, and this was what we saw. So to summarize, most of the problems that have been mentioned across the continent exist also in Ghana. And I must say that a lot of agencies are now collaborating, including the EU Alliance Foundation, to help offer some form of training to these traditional bone setters in Ghana to help minimize the catastrophic complications that they create, which we see in the hospitals. Thank you very much for your attention.
Thank you very much, Dr. Yeboah. Liz, I think let's have like maybe another 20 minutes or so. I know that we're going over, but for anybody who can join and continue staying on the call, we'll have some questions now. Go ahead, Liz.
Why don't we open it up to the group and see if anyone someone may have to leave and want to get their question in. Does that sound okay?
Yeah, of course. And also to any of our panelists, if there are any points that came up in the presentations, presenters who went after you, please feel free to share now.
Yes.
Yes, Henry, go ahead.
Okay. We've talked a lot about training of traditional bone healers. For those who have done some bit of training, because we must be very careful, you can't train them on everything. It takes 5 years for us to do orthopedics. So what are we really training them on? Because as I said, I did some form of training in terms of, well, not training, public health thing on clubfoot. I didn't go to teach them how to do the Bonesetti technique. Rather, I tried to tell them how it is better to allow those young children be treated with Bonesetti technique. I don't think I'll really advocate training them on Bonesetti technique because there are a lot of things involved. You need to go back to start doing basic anatomy. We don't have that time. So those who are advocating training of traditional bone setters, what do you want to train them on? Or what is your scope of training?
Dr. Onyemaechi, maybe you could comment on that since you've worked on that specifically.
Okay. All right. Thank you so much, Dr. Ndasi. I think this is a very important question. You and I know that, before I go into that, you know, the training of bone setters in Nigeria is still a very controversial issue. Like I said, I showed us in the study we did, a whole lot of people still believe there's no point in training them. All right. When we started this project, you know, a very senior orthopedic surgeon in Nigeria walked up to me and said, "Why are you wasting your time with this project? You ain't going to achieve nothing. Allow these people be. just go improve your practice and, everything will be sorted out. But I looked at it differently. All right. I've worked in different, areas of, southern, Nigeria. And, if you continue to lead them, if you continue to have that attitude, they will continue to cause more havoc. We come to our conferences, both at the national and international levels, and we project pictures of what they are doing, how people are having limb gangrenes, how people are having null unions and mal unions, So what are we going to do to actually, control that? So that was a question I always ask. Do we just sit back and allow these people, to continue with their wrong practices? So in one of the studies we did, my research team, we sat down and looked at, available literature, and we focused on 3 aspects of, 3 areas that we're going to focus on. The first one is patient selection. I mentioned that during my presentation. Letting them know the patient they should not even bother to, to treat. That's the first point. Because everybody who comes to them, they try to offer some form of care, whether you like it or not. They're also doing this as a means of livelihood. So, their practice is actually a means of livelihood to them. So if you come in and you say, oh, don't treat it, you need to convince them why, if they see an open fracture, because they have not been trained in infection control, they should refer them to hospitals. A lot of them will do well with closed fractures of the tibia. A lot of them, most of their successes actually around closed tibia fractures. All right, maybe single fractures of radius or ulna closed, and they just put their splints, and then they get them to heal. Some of these displaced ankle fractures, they put their splints there. The people begin to walk after 3 months or thereabout. But once there is open fracture, a lot of them would actually end up with chronic bone infection. So one of the things we try to teach them, all right, patient selection is one of the critical areas. All right, it is an ongoing thing. We just did a pilot. We just hope we can continue this training on a wider scale. And then the second one, for sake of time, is splinting techniques. A lot of times, the problems they cause is actually, they actually arise from, applying very tight splints. Okay, either they are too tight, and the patients will get on to have, some form of, gangrene, or you release the splints too late, and they don't end up with gangrene, but the muscles are already very fibrotic, so they end up with Volkmann's ischemic contracture. Okay, so we felt that for those that can, those closed fractures that they can treat, if we can, safely teach them how to apply those splints, that will play a lot of role. And those are the 2 areas we're actually concentrating in our program. Okay, it's going to be a long-term program. It's going to be very demanding, but I think it's the right step to take. We've taken the first step, and we feel it's yielding some good results. It's something that we need to sustain on a wider scale. But I think these are the 2 areas that we can actually focus on for starting. Thank you.
Thank you so much. Really quick follow-up question to that, Dr. Onyemaechi, as far as patient selection. Do you feel like they should be able to, by themselves, recognize when they should transfer, or do you feel like it would be feasible to have some kind of referral system where they're able to have a conversation with an orthopedic surgeon and work with them?
Yeah, yes. Okay, I'll answer it in 2 ways. They can actually see some very obvious things, very obvious deformities, open fractures. They can identify those themselves. And we're also trying to, encourage them. Yeah, so many of them are not happy to refer patients. If a patient comes to you and you refer, you've lost the income from that patient. So a lot of them are not very happy. And that is why we want to bring in the government, into our project to actually encourage them. There's a compensation mechanism that we propose to the government, that for each referral that a bone setter sends to a hospital, the patient or the bone setter gets some form of reward, either monetary or in kind. Okay, that will encourage them. It was tried with the traditional birth attendants. We actually try to, follow the protocol of the traditional birth attendants. You may not know that they are the ones that take delivery of women in the local setting, okay, while working in their local environment. So for the traditional bones attendants, okay, each time they refer a woman in obstructed labor or a woman in difficult labor to a maternity or to a hospital, they get some form of reward from the government, Okay, I think that project was funded by DFID and some other international collaborators. So we try to adopt that. If the government can come in and encourage them to on their own identify open fractures, they can easily see once there's a wound, there's a fracture sticking out, it's not a closed fracture, please, this is a candidate that must get to the hospital. That is in one way. And then we're also working at a referral system, okay, looking at the nearby hospitals where we have orthopedic surgeons that is closest to some of these bone setting homes. We've done some form of mapping in Enugu State to see where we have a concentration of these bone setters. And we've also gone ahead to see how, how close some, hospitals that have orthopedic surgeons are from them. And we've encouraged them to actually, refer patients to hospitals that are close to them. So working, I think in these two ways, we feel that, we can achieve our aim of, proper patient selection for this. We welcome all ideas that can help us in achieving this. But so far, this is what we have been able to do.
Those are really interesting. Those are great ideas. Malick, you had your hand up. Is there something that you wanted to add?
Do you hear me?
Yes, we do.
I was talking about training for bones traditional healers. We had 3 experiences here. The first one took place in the north of the country. One of my colleagues gathered them around 20 or 30 traditional healers and tried to show them bad outcomes and to learn them how to recognize compartmental syndrome, how to deal with open fractures. It takes 1 month or 2 months to make them understand things. And as soon as he's stopped the learning, the things restarted. So it was not a good thing at that part. The second,
Oh, I think we lost him. No, but that's a very good point. The continuity of education, I'm sure, is very important. Kohila, I see that you've raised your hand. Would you like to ask a question or make a comment?
Yeah, hi, I just wanted to share. I thought the presentations were really, really good. And I wanted to share something. I know we talk about bone setters, and here we're talking about a setting in Africa, but I wanted to let you know that actually bone setting is also quite a common practice in Asia. And so, for example, I'm from Malaysia, and there is a huge a mixed race in the country. And when I was growing up, bone setting was actually practiced, especially in the less, especially in the more rural areas. And we used to read of, and it's usually done for vulnerable people, so kids and older people generally who depend on other people to take them to the hospital. And we, I did read about amputations, and even now when I go and visit the older folk back home, they tend to visit these bone setters, and it can be Malay bone setter, could be Chinese or Indian. We don't hear as much complications, but partly I can't find any research on it. What I can find is research done in West Africa with Malaysian supervisors. So the practice is probably common, but like, for example, in my town, it's more Chinese bone setters, I think, but they will inform the patients if they feel it is something out of their depth and something that needs hospital treatment. And I also noticed there's probably not much bandaging practice or using bamboo, splintage. It's more using herbs and massage techniques. So it's quite true that probably the recognition of patients that they shouldn't be treating is a very important thing. With regards to how they stop the complications or lessen the complications, I'm not sure because there's not much research out there. But from all the presenters today, your research will be very beneficial for the wider world, actually, not just in Africa. So thanks.
Thank you, Kohila. Very important point. I think, Christina Dijon, if she's still on the line, she made a point that she also sees the complications and patients who've been treated by traditional bone setters in Haiti. So I think it's a very important point, Kohila, you've made, that this is a problem all over the world. Dr. Dada, I know you have your hand up. Please go ahead.
Yeah, my contribution has to do with the training. I think it's very important that we know the kind of training that we're going to give to these guys, okay, so that we don't validate some of the very wrong practices that they are doing. I remember as a resident doctors in the very early 2000, in 2001, 2000, thereabout, in recognition of the need to actually train them. I remember that at that time, the hospital invited traditional bone setters and had like a workshop, a 3-4 days workshop with them. Okay, tried to put them through the dangerous practices, how to avoid the dangerous practices, the time to refer the patient, what type of patient to refer, you know. And at the end of the day, the feedback we had, because at the end of the workshop, they were issued certificates of attendance, okay? But the use to which the certificates were put became a completely different kettle of fish. Because at the end of the day, majority of them went to their practices, enlarged the certificates, hung the certificates at the entrance of their centers, as it were. And of course, the National Orthopaedic Hospital then was the prime orthopedics training center, not just in Nigeria, but in the whole of West Africa. And so when you have a certificate from National Orthopaedic Hospital, you can use that to actually cause a lot of deceit, which is what these guys, many of these guys did. They enlarged the certificate, hung them at the entrances of their different practices, and showed them to the patients that, as a matter of fact, they had also gone to the prime orthopedic hospital and orthopedic training center in the country to actually get trained and certified, okay? And so I think in taking on the training of these people, which I think is necessary, if only to reduce the number of complications and the number of problems that they cause, we need to be very careful what they are taught. We need to be very clear about the objectives, and we need to have like a roadmap, okay, and be able to actually monitor what they do subsequently. Thank you very much.
I think that's a very important point. You know, a lot of the panelists have mentioned the economic factors that are in play here. And of course, if, you know, a traditional bone setter is using this as their livelihood and they are provided with a certificate from your prestigious institution, you know, I think it makes sense why they would hang it on their door to build more practice and to get more patients coming through their doors. You know, I work on research projects a lot in Malawi. That's where I have some experience, and there, you know, we don't see so much traditional bone setters, you know, fixing bones. Now, there is some like scarification practices and massages and things like that, but not so much splinting. But what's interesting is a lot of the challenges that you have all raised about lack of access to orthopedic care in the rural areas has pushed Malawians to train non-physician clinicians. And it seems to me that a lot of what you're describing would be using these traditional bone setters in the same role that these non-physician clinicians play in a place like Malawi. They are in the formal health system. They are trained, you know, not like an orthopedic surgeon, but with the amount of training that they can do some good with the limited resources that they have. Sorry to be long-winded, but the point that I'm trying to make here is there's another element of traditional bone setters, which you have all highlighted. It's this socio-cultural and religious sort of value that the traditional bone setter has in the community. Now, we can train traditional bone setters to refer specific injuries to the hospitals where there are orthopedic surgeons. But how do we address this issue of the cultural, religious importance that patients will put on these traditional bone setters? And in fact, you know, I can't remember who mentioned this, but we do not in the hospitals address the spiritual aspects of these injuries for these patients, and that may be something that they are craving. So I just would like to pose it to anybody who wants to take on that question. Is that something that we should be considering? How do we address that when we are thinking about traditional bone setting in these practices?
Well, I actually think that the way we can actually tackle this is via community education. You know, it's important that we come out in the mass media, television programs, radio programs, okay, and even using the religious leaders, first to encourage and inform our people that there are no spiritual elements to road traffic accidents. There are no spiritual elements to trauma. The average African believes that nothing bad happens, except there are some spiritual connotations that has ensured or that has caused such a bad event to happen. And they also know that as Orthodox practitioners, we don't claim to have spiritual capabilities, okay? And for them, even if the orthopedic surgeon and even if the conventional hospital, it's a lot better and would offer them the better services, for them, they still believe that for the care to actually succeed, there's the need to actually eliminate the spiritual element. And for me, the only way we can go around this is for us to actually educate the people, okay, and use whatever means that is possible to educate them. And that can also mean us engaging the religious leaders, okay, whether they are Christians or Muslims or even the traditionalists, okay, and encourage them to let them know that injuries just happen. You know, you don't have to have offended some person's grandfather or some person's grandmother in the village for you to be involved in a road traffic accident, okay? And quite frankly, this is one of the factors in my study that I found that actually encourages even highly educated people, you know, university lecturers. Some of the series that I presented, some of the patients were actually university lecturers who went, some of them are actually health workers who went to traditional Bonesetters, okay? And when you deeply interview these people, it's not that they don't have, at least the educated ones, it's not that they don't have confidence in the Orthodox practitioners. They just simply that some of them still believe that this accident or this fall that happened that made me to break my bone, okay, just didn't happen. It happened because there's some spiritual element to it, and I need to remove the spiritual element before I can be healed. So it's an important point that we really need to design some sort of communication around and push to our people. That is one way that I think we can actually handle this, because if we don't handle that, and then if we also, because like I said earlier on, yes, quite a number of them believe that Orthodox practice and Orthodox care is expensive, but the study that we did actually showed that at the end of the day, these guys actually pay more in the traditional homes. The only difference is that in the traditional homes, if what you have today is $2, then you put it down, it is taken, it's not rejected. If tomorrow you have $10, you put it down, it's not rejected, okay? If next tomorrow you need to pay for your care and you don't have any money, then you can bring a goat. It is also accepted in lieu of the cash payments, all right? Okay, so at the end of the day, by the time you put all of this together, you find out that they have actually paid even far more than they probably would pay in the Orthodox hospitals. So these are some of the issues I think if we're going to solve this problem, apart from the training that we need to give to these guys to be able to recognize the very bad injuries and the dangerous ones and, you know, change their practices, we also need to actually do some engagement of the populace. Thank you.
I think that's a very important point about education. I'd like to invite Dr. Yeboah and Mengistu also to make a comment about that, because it seems to me that the BOSAD study has a primary focus on actually trying to address these issues from the education side, trying to educate patients. So either of you, if you'd like to comment a little bit on this point, I'd love to hear your thoughts.
Sir, and Dominic? Okay.
No, proceed.
Hello, Kiran. Yes.
Yes, please.
Yes, as has been discussed so far, here in Ghana, we have equally identified that there are some fractures that do well in the hands of the traditional Bonesetters. Close, undisplaced tibial subfractures, fractures of the forearm, single bone, transverse, undisplaced radial shaft fractures, another injuries. They handle them and the results are quite good. So, and beyond that, we have over 60% of our population still patronizing their services. And there is no way we can bar people from going to them. So capacity building of the TBS is so important that we can't wish it away. So the BOSA project is trying to mobilize technical people on the ground as well as some traditional leaders to be able to bring the two sides together so that the mistrust between the TBS and the orthopedists will be dispelled so that we can engage each other on these basic principles so that we can improve trauma orthopedic care across the country for our population. Thank you.
Thank you. Mengistu, did you want to say anything? I also have a question here from the chat from Leon Baburov. How much of negative traditional bone setter outcomes are a result of bad expertise treatment versus not having access to the tools required for diagnosis and treatment? Would real-time teleconsultations with orthopedic surgeons move the needle or improve things? Or is the lack of tools, materials a larger bottleneck? Mengistu, I'd love to hear your thoughts. And I think also, Henry, you had talked about this. If you're still on the line, I'd love to hear your thoughts on that question. Go ahead, Mengistu, please.
So, thank you very much. As one component of a BOSAD researcher from Ethiopia, I completely agree with training given for the traditional bone setter. But the most important thing is we need to agree on the read zone, which patients are a candidate to be either with traditional bone setter or low and middle level health professionals, including until general practitioner, for example, in our setup, with nurses, health extension workers, and general practitioners. So we need to identify this point clearly. We need to have a clear red zone. Which patient should be referred to orthopedic surgeon should be clearly defined and should be noticed with everybody. One point is that one. For example, all of the patients who died in our setup are those patients who have open fracture. So open fracture is not amenable to be treated by anybody else because they are different entity. Pediatric patients are other vulnerable group. So pediatric patient, even the diagnosis of the fracture, the diagnosis of their injury is completely, it is not an easy job, even for orthopedic surgeons. That's why we order bilateral X-ray or something. So this thing should get a focus to be managed with orthopedic surgeon. I completely agreed with the training given to traditional bone setter, but when we give a training for them, we need to give also responsibility. Everybody should be responsible for the actions they take. That was my one of my concerns while I give my presentation. So if as an orthopedic surgeon, if I did any mistake, even if it could be infection or it could be amputation due to the procedure itself, I will be accused. I will be in court. This is a written document in the Ethiopian standard or in the Ethiopian government institution. So whenever the traditional bone setter do something, we should not spare it. As the orthopedic surgeon or anybody else is responsible for the action, they need to be also responsible. We need to have that system. That is the whole point. Yes, the big problem is most of the people, most of the personnel, including health practitioners, they took their kid to traditional bone setter. I don't know why. I don't know why they can't think their kid deserve evaluation by orthopedic surgeon, even we are on their hand. I don't know. Anyways, those people who are working in the Federal Ministry of Health, they took their kid, they get massage for their ankle sprain, they get massage for their wrist injury or something. Even some nurses brought their kid after they get massaged at the elbow while they have distal fracture. When the nurse brought her kid to our clinic and when I sent X-ray, he has distal fracture. But he was getting massaged by traditional bone setter at the elbow. As she said, the traditional bone setter held for her like he has elbow dislocation. You can imagine. Probably in association with the question asked from Leon too, The problem is orthopedics is completely different, as we all know. It needs investigation, it needs X-ray at least. Some of the fracture may need further investigation to pick. We have patient with tibial plateau, who is a football player in one of the club in Hawassa. He's 17 years old. He was having tibial plateau. He was taken to one of the health center, and the nurse there, what they say was, you have soft injury, no fracture. So he was taken to traditional Bonesetter, and they get massaged. At the end of the day, he started to have discharge from the fracture site, and he started to get weight gangrene from his leg. So we did above knee amputation. We didn't do only, it is not all about amputation. It is not only amputation for him. It is not lose of limb for him. It is lose of hope, lose of life for him. Because he's not student, he's not doctor, he's not anybody, lawyer. He is a football player in which he needs his leg. So it is a big concern. We can't say just give training for traditional Bonesetter, but if we plan to give traditional Bonesetter training, we need to make them responsible. The most important thing that we all need to underline is orthopedic patients, they need appropriate evaluation and appropriate management. That's the whole point. Otherwise, anybody can, if he has the capacity to interpret investigation, to order investigation and give appropriate treatment, that's okay. My last point, there is a known traditional Bonesetter here in Hawassa, in which he see in one of the presentation, one of the known traditional Bonesetter, he gave the chance to visit, I guess, 30 patients per day. But this guy, he gets more than 50 patients per day. You can imagine how his under quote unquote, his clinic is very busy. You can imagine. But you know what he did? He's too smart. He ordered X-ray, but he doesn't know how to put it, how to interpret. I get one of midwife who take her kid elbow X-ray for him, and he put it down, and he say, oh, the injury is here at the wrist. So if we train them, we need to train how to interpret investigation as well, which is really difficult. For me, we need to prepare scope of practice. I will agree with all my colleagues or all the presentations that's given, but we need to customize to our local standards or to our local circumstances. For Ethiopia, I will not go and train traditional Bonesetter to do splinting, to do this and not to do this. The first thing is every pediatric patient, specifically, they need to have legal guardian. There should be a legal background for any injury which caused by either orthopedic surgeon or traditional Bonesetter. That's the whole point. So thank you. That's the points that I can say.
Thank you, Mengistu. You know, I feel like we could just continue talking and talking and talking about this incredibly important and relevant topic. But for the interest of time, I say that we end the conversation there. I would also like to say that the interest in this panel and the interest from all of the attendants has been really strong. And I think that we should continue this conversation, whether it's in the form of more panels, more discussions, more communication between all of us. So Liz, please, I'll let you say the last word and take it away.
Thank you so much, Kiran. This is so exciting to see so many people from all over West and East Africa getting together. It's such a pervasive problem, just like Kolia shared. You know, it's something that's not just in Africa, it's everywhere, you know, Turkey, Asia, etc. And it's something that I think we'll have a better chance at combating and coming up with a solution for if we continue to share ideas and figure out what has worked and share data. So thank you very much for everyone who has come, and we'll leave it at that.
Thank you, everybody. I'm just going to put my email in the chat box for anybody who would like to know about future events and stay connected with HGOC. Thank you. Big thank you to our panelists. Thank you so much.